Good morning, good afternoon, and good evening, philosophers, and welcome to episode 15 of Philosophy of Science Through the Lens of Medicine. Today we're asking a question that sounds innocent, but becomes politically explosive the moment it enters a health ministry. Is medicine a fundamentally Western phenomenon? To answer it, we must first ask what medicine is actually for. Ask patients in a waiting room, and you'll probably hear some version of "to make me better," and preferably before I finish reading this 6-year-old version of Good Housekeeping. Philosophers usually express this more soberly by saying the aim of medicine is to cure. But cure can mean different things. Strictly, it sort of means eliminating disease and returning the patient to full health. The patient leaves restored like a laptop after a suspiciously expensive factory test. But more broadly, it includes any reasonably effective intervention that improves the patient's condition, reducing symptoms, slowing deterioration, or preventing disease. Insulin doesn't eliminate diabetes, but prescribing it is hardly peripheral to medicine. In this debate, cure is often used generously, covering complete restoration and meaningful therapeutic improvement. There is fairly broad agreement then that cure, in this broad sense, is medicine's goal. Alex Broadbent's clever move is to distinguish a profession's goal from its core business, the competence its practitioners must reliably possess for the profession to survive. His argument begins with an awkward historical fact. For most of human history, medicine was not very good at making people better. We've discussed this in the medical nihilism lectures. Bloodletting, purging, and enough mercury to concern a mining regulator are not exactly highlights of therapeutic success. And yet, medicine persisted. Broadbent uses the example of a taxi driver. The core business of taxis is getting passengers from A to B. If taxis routinely deposited us at C, or in another province altogether, the industry wouldn't last. You must be reasonably good at your core business, or people stop paying for you. So, Broadbent's argument from the Persistence of Ineffective Medicine runs like this. If curing were medicine's core business, medical traditions that could not reliably cure would disappear. Many ineffective traditions did not disappear, and so curing can't be medicine's core business. Okay, so Broadbent doesn't conclude that cure is irrelevant. Cure remains the destination, but medicine's core business, he argues, is inquiry directed towards cure. Its central intellectual competence is understanding health and disease. Its central practical competence is prediction. A doctor may not cure you, but may explain what's happening, predict what comes next, and assess different interventions. Medicine can perform its core business while falling short of its goal. And this is where smart enters the debate, which is me, so you should make the usual adjustments for possible author bias. My objection is that Broadbent has made the curative thesis too demanding. Professional competence can't mean guaranteeing success. Lawyers remain lawyers after losing cases, teachers survive students learning nothing, and economists have somehow survived despite, well, everything. The more plausible view is what I call the best available intervention thesis. Medicine is a sustained and organized effort to determine and prescribe the best available curative or preventative treatment for patients. The important words are best available. A doctor is not incompetent because a disease is incurable, or the best treatment has a modest chance of success. They are incompetent if an appropriate treatment is available, and yet they fail to identify it. The competence isn't producing happy outcomes on demand, it's finding this patient's best therapeutic option. Available is, of course, partly relative to the practitioner's medical paradigm. A sangoma is not expected to know every Western pharmaceutical, just as a GP is not expected to prescribe an ancestral ritual. This explains medicine's survival differently. Sick people want to recover, and a practitioner may offer their best chance. People buy lottery tickets knowing that retirement on a private plane is unlikely, but they still buy lottery tickets. When the alternatives are small chance of improvement and continue suffering, hope can sustain a profession. Treatment need not follow deep understanding. Willow bark treated pain long before anyone knew its active ingredients. Lithium can help bipolar disorder despite incomplete mechanistic understanding. Trials may show that something works long before explaining how. So, understanding is valuable, but medicine can't always wait for it to finish its homework. Now, let's return to our title. If medicine is defined as a system using Western biomedical theories, laboratories, and randomized controlled trials, then, of course, medicine is Western. But that definition wins the argument by hiding the conclusion in question. The best available intervention thesis asks what practitioners do, not whether they can own a white coat, an MRI machine, or the ability to invoice a medical aid. Traditional Chinese medicine contains organized diagnostic and therapeutic practices, transmitted through recognized traditions and used to select interventions intended to prevent illness, relieve symptoms, or restore health. Patients consult its practitioners hoping to recover. It therefore meets the criteria. The same applies to traditional African medicine. Although there's no single uniform African medicine, healers work within varied herbal, spiritual, familial, and communal traditions. In South Africa, sangomas may locate illness partly in relationships with family or ancestors and prescribe within an indigenous knowledge system. Patients seek cure or relief. The practice selects treatments, and healing is the goal. So they too qualify, no? That doesn't imply that every intervention works. Calling something medicine is a classification, not a 5-star review. Bloodletting was medicine while harming patients. So we must separate, is this medicine, from is this safe and effective medicine? The second requires evidence and applies equally to mainstream biomedicine. Nor is the account infinitely permissive. A random drug seller does not become a doctor by writing wellness on the packet. The practice must be sustained and organized, use a recognized methodological or epistemic tradition, be sought for treatment, and make cure or prevention its primary goal. So, is medicine fundamentally Western? No, I don't think so. Contemporary biomedicine has been shaped enormously by Western institutions, but medicine is a broader human response to illness, organized attempts across cultures to find the best available way of helping sick people. Yet, qualifying as medicine hasn't produced equal institutional standing. Traditional African medicine remains largely marginalized in public funding, healthcare infrastructure, clinical guidelines, and official advice. There may be good evidence-based reasons not to fund a particular intervention, but that differs from excluding a whole tradition because it doesn't resemble Western biomedicine. And that leaves us with the next question. If medicine isn't fundamentally Western, why are our healthcare institutions so overwhelmingly organized as though they were? In the next video, we're going to look into decolonization a little bit and discover what it might mean in the healthcare context. Until then, please like and subscribe, and remember, sometimes the most interesting philosophical question in medicine isn't does it work, but who was allowed to decide what counts as medicine in the first place? I'll see you on the next one.